you can see my first slide, and I'm being put forward as an expert on this. In fact, I don't think anyone can be an expert on COVID-19. There are 5,000 plus publications every week in the scientific and clinical field of COVID-19. How on earth could anybody keep up with those 5,000 publications a week? So I'm only going to give you my own views and hope that they will be of interest to you. And it will be a minor view of COVID-19. It's impossible to be an expert on what has turned out to be a huge field. Well, what is COVID-19? Well, COVID stands for coronavirus disease originating from China. So that's the COVID. It's caused by the SARS-CoV-2 virus. SARS standing for severe acute respiratory syndrome, coronavirus number 2. It's labeled as SARS-2 to distinguish it from SARS, which originated from China in 2002 or so, but which did not progress to a pandemic and which is not currently circulating. I think we need some basics as well. What is a virus? Well, you may be amazed to learn that all living forms of life have viruses. Whether you go from a protozoa to a bacterium, to a duck, to a crab. Now, when we're thinking of how many viruses does each species have, it's an impossible number because those that are of major interest have been studied the most. So we know there are several thousand human viruses that are known and researched. And when we look at our close domestic animals, particularly the horse, the cat, the dog, the chicken, there are hundreds and hundreds of viruses that are attributed to these domestic animals. Probably you are carrying many, many millions and trillions of viruses at this very moment because your gut is full of bacteria, and there are many bacteriophages, which are viruses that infect the common bacteria in your gut. There are many billions of bacteria in the gut and probably trillions of viruses. The bottom right-hand corner shows you what a bacteriophage looks like. So we are very familiar with viruses, even though we may not know it. This is the basic structure of a virus. We have the genetic code, which can be DNA or RNA, an outer shell or membrane, and then the most important part of the virus is the receptor that it uses to tag on to the cell that it's going to infect. And it will be a very specific receptor. For COVID-19 or SARS-CoV-2, we know that it is the ACE2 receptor. That's the angiotensin converting enzyme receptor number 2. And if you've never heard of it, well, don't worry. But many of you may be taking ACE inhibitors to control blood pressure. This receptor is widely spread throughout the body, and it's a very conserved receptor. And those are the sort of receptors that viruses go for. They go for receptors that are common within the body and which are conserved and are not going to be changed very quickly. And ACE2 is one of those. This is the coronavirus, and the size is about 100 nanometers across. Well, you can see the scale on the bottom there, a centimeter and a millimeter. Well, 10,000 coronaviruses laid end to end would fit across a distance of 1 millimeter. So you can hardly imagine how small these viruses are. When we're thinking of the common cold virus, like the rhinovirus, that is only about 20 nanometers across. So you could get 50,000 or 50,000 rhinoviruses across that 1 millimeter gap. They're unbelievably tiny. And it's amazing to think that something so tiny can overwhelm very sophisticated organisms like ourselves. Viruses are parasites that reproduce inside living cells. They've got to get inside a cell to hijack its machinery, rather like a computer virus. Antibiotics have no effect whatsoever on viruses because they don't metabolize. They use the human cell's metabolism to actually reproduce. How do we catch SARS-CoV-2? Well, it's a respiratory virus, and respiratory viruses have relatively easy access to animals. A human adult will breathe around 10 to 15,000 liters of air a day. That's a huge amount of air taken in. And viruses, therefore, are going to have easy access taken in on the inspired air. Viruses can also infect us via the eye, the respiratory viruses, because once a respiratory virus gets into the eye, perhaps someone coughs or sneezes and a droplet enters the eye, it will pass down the tear duct into the nose. And once it's in the nose, of course, it's got easy access to the respiratory tract. So if you want to protect yourself as well as having a mask, you really need to protect your eyes with goggles as well. So this is the way the virus is spread. You can see on the left-hand side, the infected person. They have a mild upper airway illness, socially mobile patient, so they can move about in the population. Viruses that make us very ill are not very successful, particularly viruses that kill us, because if you're walking around, going to school, going to work, going to the cinema, that is when you're going to be spreading the virus. The virus really evolves to give you a mild illness. That's why the common cold viruses are so common. And of course, we produce respiratory fluid, a mixture of mucus and plasma, and that respiratory fluid can be coughed out or sneezed, and the aerosol can then go across to the contact, who can breathe in that infected aerosol. Of course, the infected fluid can be passed on to what are called fomites. That's the posh word for dirty surfaces. And if you touch those dirty surfaces and then put the hand into the eye or the nose, you've completed the chain of infection. And hand to nose or hand to eye contact is probably a very common way for spreading influenza, common cold, and also COVID-19. In our crowded cities and at home, we are constantly exposed to viruses, constantly. And really the only way to avoid viruses is to avoid all human contact, become a hermit. You won't pick up any viruses unless, of course, you're snuggling up to animals that may be carrying a virus that can jump to a human being. We're all learning that social distancing and hand washing are the only real ways to avoid infection. And social distancing will mean that the aerosols can't reach us, and hand washing, of course, will mean that we can get rid of any contaminated mucus that we picked up on our hands. Well, why is SARS-CoV-2 so different from other viruses? Because it is different at the moment. It's different and it's difficult because it's a new virus for mankind. If we look at how we've actually acquired this virus, the evidence indicates that it's the Chinese horseshoe bat that is the source of this coronavirus. Bats in China carry over 400 different types of coronavirus. That's a huge variety of coronaviruses and a huge reservoir. It's believed that in some way the horseshoe bat infected Chinese pangolins, which are another a rather primitive mammal. And these pangolins can be sold in the wet markets in China. Of course, it's illegal to sell them in the markets, and that's why there are no records in Wuhan of these pangolins being sold. But everyone knows, and certainly the Chinese know, that they are sold in markets. And it's likely that someone has picked up the body fluids or the respiratory fluid from a Chinese pangolin infected with a Chinese horseshoe bat coronavirus, and by chance that virus has managed to succeed in infecting human beings. Humans already have 6 coronaviruses. We have 4 coronaviruses that we've all had. Every one of you will have had these coronaviruses because they are common cold coronaviruses and they cause a mild illness. Maybe in the past they caused severe illness, and the virus has gradually evolved to become successful by causing a mild illness. Middle East respiratory syndrome and severe acute respiratory syndrome are 2 other diseases. Recent coronavirus transmissions from animals to man. Severe acute respiratory syndrome 2002, 2003, again from China via the civet cat. The civet cat is another of those animals that the Chinese seem to like as a delicacy, and they get exposed to the body fluids. But of course, SARS didn't spread very well. The virus didn't get the trick to actually cause an illness in human beings where it could spread from one human being to another easily. But don't blame the Chinese. We may blame the Chinese for influenza and a lot of these other viruses, but actually Middle East respiratory syndrome came from Saudi Arabia. Those camel herders were nuzzling up too close to their dromedary camels, and they picked up that coronavirus. But again, the Middle East respiratory syndrome didn't spread very well in human beings, and therefore we don't have it circulating. So SARS, the first SARS and MERS did not become pandemics. Well, why is SARS-CoV-2 so dangerous? Because it is dangerous. It's dangerous, firstly, because it's a novel virus and we have no immunity to it. No human beings have been exposed to this. So it's almost like a virgin forest that can be burnt through. But probably it's dangerous also because it spreads so easily. It spreads easily because it can cause a mild illness. It's dangerous because it infects the lungs. So it's not like a common cold virus, which tends to stick up in the nose and throat. It can get down the trachea and it can get into the lungs and it can replicate in the lungs. It's also dangerous because it can infect other organs such as the heart and the kidneys. Remember that receptor that I said, the ACE2 receptor? It's not just found in the respiratory tract. It's found on most of the tissues of the body. So the virus can spread to the brain, it could spread to the heart, kidneys. But probably most importantly, the virus is so dangerous because it causes mild symptoms in many children and adults. And those people can go around spreading the virus in the community. If it only caused a severe illness, those people would be in hospital and they'd be not spreading the disease. So SARS-CoV-2 is dangerous because the majority of people, probably 80–90% of people who get SARS-CoV-2 have a relatively mild illness and they may not know they've got it. Recent research in China has shown that very large numbers of people have the antibody and they never knew that they were infected. As at August 7th, worldwide, we're looking at 712,000 deaths from COVID-19. But it may not be as dangerous as influenza. We tend to discount influenza, but remember, the pandemic that we had in 1918 killed between 20 to 50 million people worldwide. Well, we've not reached 1 million yet with COVID-19, according to the WHO. It probably is 1 million because not all of the deaths are registered. But every single year, there are at least 650,000 deaths from influenza. So influenza is the big killer at the moment. It can dwarf COVID-19. Disease is a problem for the elderly, not for young adults and children. Let me take you through this graph. Can you see the little blue dots on the graph that are going across from left to right? You can see that under 1 year, we've not got any COVID. Sorry, that's a 2015 average deaths. So the blue dots are giving the average deaths between 2015 and 19 on an annual basis. So you can see that if you're very young, you're very unlikely to die. There's a very low incidence of mortality. As we creep up the curve, you can see that by 85 plus, we're looking at around 3,000, 4,000 deaths every year in the UK. But those are the annual deaths that are normal. If we look at the grey column, it shows the number of deaths that we're seeing this year. And you can see that's above normal. It's above normal because we've probably got people who've not been presenting to hospital, who've not been presenting to their GP, and therefore the actual mortality for this year is on a monthly basis is above normal. The orange top little bit shows you the deaths related to COVID-19. And you can see if you're 85 plus, there's a significant orange part to the graph. And if you're between 75 to 84, there's a significant orange part. But when we get down to 45 to 64, there's very little orange, very little death attributed to COVID. And when we get down to 15 to 44, we're not getting hardly any. And between 0 to about 40 years, there's very little death associated with COVID-19. It's not even showing on the graph. So I think if we look at the grey column, if you're in the elderly group like myself, you look at the grey column and you can see you're much more likely to die from other causes than from COVID-19. Maybe we find that reassuring, I'm not so sure. But COVID-19 is not the biggest killer. In fact, dementia is one of the biggest killers when we look at the mortality. Well, it's interesting that the virus infection causes very little damage. The damage caused by the virus is not what is killing us. It's our own exaggerated immune response that causes damage to the lungs and other organs. It's almost as though our immune system goes into overdrive because it's never seen this virus before, and we get a huge amount of inflammation. Well, the inflammation in the lungs will cause a lot of fluid, and that means that you can't breathe properly. You gradually lose the capacity to transfer oxygen across your lungs. And of course, that inflammation will also cause fibrosis, a fibring of the lung, so the lungs become more rigid. And unfortunately, that can persist after you've recovered from the COVID-19. So you can be left with some permanent lung damage, not caused by the virus, which is causing very little damage, but caused by an exaggerated immune response. What about treatments for COVID-19 if you are unfortunate enough to end up in hospital? Well, the obvious one is oxygen, because your lungs are not able to transfer oxygen so easily once they're inflamed. If you become very sick and weak so that you can't ventilate your lungs properly yourself, you could go onto a ventilator to assist with gas transfer. But the ventilators actually been put forward as causing lung damage. They can actually damage your lungs if you're on a ventilator for any extended period. So often now what is given is what's called continuous positive airway pressure plus oxygen. CPAP, as it's called, is what people take when they're suffering from sleep apnea, and they use it every night. It's a little pump that keeps the airways open. And of course, you would be given intravenous fluids, and if necessary, if you've got bacterial infections on top of the virus, you'll be giving antibiotics. But those are really all measures to just sustain us. What about actually attacking the virus? Well, there are antivirals for Ebola, HIV, etc., which are being used, and they do have some effect on the SARS-CoV-2 virus, but it's not a major effect. They may be saving 20% of the lives of the severely ill. But 20%, if you're in that 20%, that's a good thing. Your life is saved. Of course, I've mentioned that the immune response goes into overdrive, and that is what can kill us. So steroids like dexamethasone and others can be given to dampen down the inflammatory response and dampen down the immune system. Chloroquine's been put forward by President Trump and others, but the clinical trials for chloroquine and hydroxychloroquine, which are used to treat malaria, and also as a cleanser for fish tanks, surprisingly as well, these have not been shown to be very effective, and they can have some serious side effects. Another molecule which has become of interest is interferon. That's part of our immune response, and it can be given in a nebulized way. And what it does, it switches off the cells from producing viruses. So it can switch off the viral replication in cells and can be given in a nebulized way. Where is SARS-CoV-2 going? Where is it going? Well, of course, it's going around the world. I was looking up, where has it actually gone? And it's easier to say, where has it not gone? If you look at those countries which have a very dictatorial regime in some of the Balkans and some other countries, they didn't report any infections early on. In fact, they were infected, but they didn't want the population to know, and the infections are spreading in those countries. There may be one or two very isolated Pacific islands where the COVID has not reached, but it's going to reach there eventually. So all countries across the world are infected at present. It is a huge, huge pandemic. And even countries that have got rid of it, like New Zealand, they are in some fear of reinfection, because remember, all of that population in New Zealand really has no immunity against the virus. And if the virus gets going in New Zealand or anywhere else like that, it will go through the population very quickly. So will COVID-19 die out eventually? Well, I think our greatest hope, and I do have a lot of hope, is with vaccination. I think there are over 90 different vaccines being developed around the world. The UK government has already put millions of pounds into 4 or 5 different vaccines and ordered many, many millions, hundreds of millions of doses of these vaccines. I think out of those 90 research projects on the vaccine, which are looking at very different ways of producing vaccines, I'm pretty confident we're going to get vaccines. We are going to get vaccines. The big question is, how effective will the vaccines be? Will we have to take them once a year? Will we have to take them twice a year? But we will have a vaccine, and I think the vaccine is likely to come later this year or in spring. And I think that would be the game changer, because I think if we have vaccination, we can control the disease very effectively, and you would be able to travel with a vaccination certificate. And I'm optimistic about that. The other aspect is, are we going to see a natural decline in infections? Well, until all of the people of the world have been infected, we're not going to see that natural decline. I think what is happening, what does appear to be happening, is that more and more mild infections are occurring. Already in the UK, we've got dozens of different strains of the SARS-CoV-2 in circulation. So there may be a natural evolution of the virus to cause milder infections. That's a possibility. Remember, we've already got 4 coronaviruses that cause common cold. So we may see a natural decline, not just in infections, but actually in the seriousness of those infections. But I think the virus seems here to stay. I don't think we're ever going to eliminate this virus from the world unless we have a very powerful vaccine and use it in the same way as we did to eliminate smallpox. But look how long it took to eliminate smallpox. It was many decades. So I think we are here to see this virus for many years to come. But as I've said, with vaccination, perhaps a natural decline in the morbidity of the infections, perhaps with new antivirals which are being developed, we will be able to control it. And the new normal is not going to be the normal that we're in now. It'll be a much better normal than we have at present. Well, what are my personal opinions? China and the WHO first. Well, I think they've both been rather poor in handling this. I think China, with its secretive administration, did not tell us what was going on. In fact, in 2016, there were infections in the northern parts of China, which the virologists in Wuhan were investigating, and people were dying. And the Wuhan scientists published some very nice papers about those, but they never said people were dying in the northern provinces. It was kept secretive. And even when the virus came out in the wet market in Wuhan, it was also relatively secret and the whistleblowers were shut up. Taiwan was reporting serious cases really before China. It had already got across to Taiwan. And the WHO really did not ring the alarm bells early enough. Maybe in retrospect, it's easy to criticize them. But I think when we saw the cases appearing in Taiwan, there should have been some serious alarm bells ringing in the WHO. How did we do in the UK? Well, I think we've done very badly. I think our lockdown came much too late. We had very big events going on in Wales and in England, which should have been shut down. We had the Cheltenham Race Festival. We had international matches. We had footballers coming from Spain to Manchester spreading the disease. And we should have shut down much earlier, and we didn't. And of course, that meant the virus was then scattered right across the UK. And it was impossible then to use trace and track. There were too many hotspots. So we've done poorly. We also tended to move people out of the care homes without proper testing. And that again spread the virus into care homes in the most vulnerable of the population. Our trace and track has been abysmal. We've had a very poor trace and track operations in the UK. And really, we should have done much better as a developed country. Maybe it's easy for me to criticize in retrospect, but I think one of the things I would not have done at the beginning was probably to shut the schools down. The schools were shut down very quickly. We probably didn't need to do that. If we look at the way the virus is spread, children don't appear to spread the virus very well or at all. And it appears that the children are picking up the virus from adults rather than from other children. So I think we can probably open the schools with some confidence that the teachers are not going to be at great risk and there's not going to be great spread into the community. Well, I'm coming to the end because I wanted to leave plenty of time for questions. This is a very nice cartoon, which I love, from Ogden Nash, saying from Ogden Nash, that a family is a unit composed not only of children, but of men, women, an occasional animal, and the common cold, or we could say the common cold virus. And I think that's where the coronavirus, SARS-CoV-2, is going to end up. Hopefully in a happy family as a very mild sort of common cold disease in the future. But we'll wait and see what happens. And I think Richard is in charge now, and I'm happy to answer any questions that have come up. Do I pass the share over to you, Richard?
Yeah, maybe if you can stop sharing, and then if you then pass the host back over, that'd be great, thank you.
Right, I've stopped sharing. And I go to participants, is it?
If you find me and then click on
Richard.
more.
I've got Richard, more. There. I've put you back, Richard.
That's great, thank you very much. Well, I mean, I don't know if David wants to say a few words, I mean, before we get into questions.
I don't think there's a lot more to that. I think that was very, very interesting. I think people have actually had a number of things explained to them, and I think the best thing would be to move to questions.
Okay. I did get sent a couple of questions before, so I think what I might try and do, rather than me ask the questions, sorry, my wife's just printing. Sorry, I thought I'd maybe ask Nick Hawkins, you had a question. Do you want to unmute and ask the question to Ron?
Yes, I will do. Perhaps I should have written it down. I've just to say that from an association point of view, this is a bit of a curveball, by the way, Ron. From an association point of view, we're looking towards potentially planning a Christmas event in Station Road, of course, and also for the May Festival. Both of these include quite large outside gatherings, and indeed inside gatherings of up to 100 people. The question is that from your point of view, what would you advise us to do in terms of our future planning?
I thought you would ask an impossible question. I think it's totally unpredictable, but at the moment it's going to depend on perhaps if we've got a vaccine. I don't think we're going to have enough vaccine around by Christmas to do it, but who knows? You know, things can move very quickly. I think we're so lucky in Wales at the moment. Our incidence is down to what, about a dozen a day out of 3 million people. So you're much more likely to be struck by lightning in a thunderstorm at the moment than to get COVID-19. Probably not struck by lightning, but struck by a car anyway. That's probably a bit more common than being struck by lightning. So, you know, there's very little risk in Wales at the moment. But as we've seen in Leicester and Preston and Belgium and other places, things can change very quickly. And at the moment, I would say it's high risk to have large gatherings towards Christmas. But I think you just have to follow our First Minister with his broadcasts and see what's going to happen in Wales, really. And I think at the moment we're allowed up to 30 people to gather together. Is that going to change? I think it's unpredictable. I'm not going to stick my neck out. I think there's some high risk at the moment of having large gatherings. Outside, of course, is so much better. So much better, but people can be close together and they can cough and sneeze on each other. That's the problem.
I just said, I just made a comment on that. I mean, as you correctly said, it's an impossible question, but I thought I'd ask it anyway. But the situation is partly what is feasible, and the other is what is allowed. And I think that it is the natural tendency of government, particularly through our First Minister, to err on the side of caution. And I think that is going to dictate what we're allowed to do. And the problem that we have from an association point of view, and anybody in our community who's trying to organise something, is knowing at what stage things will be open out, given that the sort of events that I've been talking about do take quite a long time to organise. Christmas is probably too soon, but the May Festival, we may not be, we could do a great deal of planning and then throw the whole thing away, or we could actually start planning very late and have a very much lesser festival. Those seem to be the two options.
Thanks, Nick. Could I ask a question, please, Ron? A couple of questions, really. I suppose one is around my understanding of people who are showing they've got the antibodies, and what sort of protection does that give them, and is there any evidence to suggest how long that protection might last for? And my second question is, you mentioned about passing it through surfaces and in the air. I've heard all different sorts of reports about how long the virus can survive on surfaces and in the air. Can you give us a bit of a feel for that as well, please?
Right, but there's still ongoing research as far as the antibodies are concerned. The latest research that I've read from China, and there's a lot of research coming out of China because they've got some very good scientists, and that's where it all started. They've looked at patients who have been in hospital ill with COVID, and then they've looked at the decline in antibodies over a period of months. And it's not good news, I'm afraid, because what they've shown is after 3 or 4 months, there's hardly any antibody left. So there's a huge decline in antibodies, not long lasting. And of course, that makes it very tricky to develop a vaccine, because if the actual illness is not giving you a long lasting immunity, then we're going to need a damn good vaccine to generate immunity. So the antibody test at the moment is not giving us any good information. It's probably not worth having, because even if you've got antibodies immediately after the infection, you may not have enough antibodies to prevent another infection in a few months. So that's the present understanding. Of course, you know what science is like. Somebody may come out with a different publication from what the Chinese have produced and say, well, in some people, maybe the antibody response is prolonged. That's a possibility. Some people may be lucky, and we know some people are lucky with the virus. Some go down very sick, and yet someone of the same age and without any other diseases goes along with a mild illness. So genetic variation is a big factor. Now, the other question was, what was the other one?
It was about how long the virus can survive in the air and on the material.
Right. Well, there was a publication in the Journal of Hospital Infection, which I picked up and criticized. They had cultured virus, COVID virus, and applied it to different hard surfaces and found that it could survive for up to 9 days on those hard surfaces. Now, of course, that was starting to come out in the news, and people were saying, well, should I put my Tesco shop in the garage for 9 days before I touch it? You know, and I was riled about this, so I wrote into the Journal of Hospital Infection, and there is a letter published there in public domain hammering these people, because what they'd not considered is that viruses are not transmitted in a nice culture medium. They'd painted their culture medium onto the hard surfaces. Viruses are transmitted in respiratory fluid, or between you and me, snot. And respiratory fluid is a hostile environment for viruses, because firstly, it will contain antibodies that will latch onto the viruses. Secondly, it will contain huge amounts of the white cells that attack the viruses. And these white cells have an enzyme, a peroxidase enzyme, that damages the viruses and neutralizes them. That's why your secretions change from clear to yellow to green, because the peroxidase enzyme in the white cells has a bluish green color. So when you're looking at green snot, you're looking at green peroxidase enzyme from countless millions of white cells. So the viruses are only going to survive a matter of hours on hard surfaces. I would put the outer limit as probably 24 hours, but it's more likely they've all gone in four hours or so. So anything that's left for 24 hours will self-sterilize as far as the viruses are concerned.
And what about in the air?
In the air, they'll come down very quickly. I mean, when we cough and sneeze, we produce two types of droplets. The big droplets will infect people perhaps up to 1 meter away. They're fairly big lumps that are probably 30, 40 microns in diameter. When you get down to 10 or 12 microns in diameter, you can still have a lot of viruses in that small particle. That particle can stay suspended in the atmosphere for many hours. So you could have someone in a room that's been coughing, and then they're no longer in the room, and you go in the room and you could get infected. That's a possibility. But you probably have to go in the room 4 or 6 hours after the person. If it's longer than that, then again, the enzymes, etc., in the respiratory fluid will have started to damage the viruses. So after 4 to 6 hours, the aerosol, even the fine aerosol, is probably not infectious.
Thank you. Dave Southard sent an email question in. David, do you want to ask it? I mean, it might have been answered from Ron's presentation, but more than happy that you posted to him.
My question, Ron, is...
Hi, David.
Hi. My question, Ron, is when do you think it'll be all over?
Well, that's another big question. I think there are several stages to this, in that we have got over it to some extent in Wales. We're down to 12 a day with out of 3 million people being reported. But of course, it's smouldering and it can flare up. You know, particularly if we get crowded bars and restaurants or a big public event and there are a few infected people in there. So it can flare up. I think it's going to be over for us older ones when we've got an effective vaccine, because the vaccine will go first of all to the frontline workers, perhaps to key workers like police, and then it'll also come to us older persons, because they don't want us to end up in hospital. But when a vaccine comes, I think that is going to be over for us. We're going to be protected. Maybe we'll have to be vaccinated twice a year initially until they get a really strong vaccine or until the virus weakens. But at least we'll be clear, we'll be safe. So the vaccine is the other thing. Then over a period of probably months to years or perhaps a decade, because it's very difficult to predict, the virus is going to become milder. It will become milder and give just a common cold-like illness. That's quite likely. So I think those are the three things we put in the equation. But I'm hoping that by spring next year, we'll have a vaccine. I will have been vaccinated, and I will be fairly confident to mix with everyone else.
Thank you.
Thank you. I don't know if everyone wants to see, but Simon Smales put a comment on, a general comment to everybody about the situation, the difference between England and Wales. So feel free to have a read of that. I suppose I haven't any more questions, but I thought I've got you all on a gallery view. So if anyone wants to ask a question, by all means, put their hands up.
I've got a question, Richard.
Yeah, David.
Ron, I know one of the big things that people seem to be very worried about is the effects of having COVID-19 and influenza in the wintertime. I'd have thought that one of the things, while people are saying that, you know, that the flu is bad, the fact that people are now social distancing much more, people are being much more hygienic, they're washing much more, isn't it likely that we're probably going to have a smaller incidence of influenza this year rather than the normal levels, and therefore there wouldn't be this sort of normal levels of flu around?
You're spot on. I can see why you're chairman there, David. You know, you're spot on with that question. Remember, the influenza season has already gone through Australia, because we're coming to the end of their winter. They've had a very good influenza season with very little influenza, and they're putting that down exactly as you say to social distancing, hand washing, and wearing masks in crowded places. So I think the influenza season is going to be impacted greatly this year. Not only that, the common cold season is going to be greatly impacted. Because remember, common cold, influenza, COVID, they all transmit in the same way. If we keep socially distanced, if we wash our hands, then we're going to knock influenza for 6, and we're going to knock common cold for 6. It's how long we can keep it up, I think. But maybe there's a new normal. We're all going to be aware of our distance from people, and we're all going to wash our hands much more than we ever did before.
Thank you.
I'm just scanning everyone's face. Anyone else want to ask a question of Ron? Simon?
Well, could I just perhaps make one or two comments from Ron, from a public health perspective? And some of you probably know that I was involved in the public health body for Wales for a number of years. And it's very interesting that the difference between what has been happening in England and what has been happening in Scotland and Wales, it can be related to some extent to the strength of the public health services in the 3 countries. The Welsh government some years ago set up an all Wales public health service, which was managed by a board and has quite a large number of quite well versed, seriously minded public health physicians. In Scotland, a similar thing has happened, but in England, about 5, 6, maybe slightly fewer more years than that ago, England basically abolished the health service public health system. And instead of having it run by the health community, it's been put into the hands of the local authorities, who took the budget and promptly raided the budget for other matters not to do with public health. And so in managing an epidemic of this sort, one of the traditional methods of tracking and tracing has been to have local organizations who wear out their shoes pacing the streets to find the people who are suffering and who are spreading the illness. And there's a very amusing little phrase which describes this practice called shoe leather public health. People wear out their shoes by tracing people who are who are spreading the infection. And that particular principle was completely ignored when the government, in its wisdom, decided to spend millions, if not billions of pounds with a non-medical agency to run the track and trace system in England, which has been an utter disaster. So I think that the fact that public health in England has been so poorly served is also reflected in the fact that the government has not been getting as good advice as they should have done. When there's been good public health advice, for example, in Mongolia, which was right next door to China, Mongolia has had practically no infection whatsoever, because the public health people in Mongolia were locally based, shut down their borders more or less at the moment they found out about what was happening in China. And they've had hardly any infections whatsoever. So I think it's probably worth emphasizing the importance of the public health system here. Ron may want to comment.
Thank you.
Yeah, I think we're doing very well in Wales, and I keep my fingers crossed that it continues. I think there are many factors, and I think the public health system is so important. And I think we now are respecting the messages that are coming across, and I think we realize we've done well and we want to keep doing well in Wales.
I was muted. Any more questions from anybody? No? Okay. David, do you want to draw a
Yes.
conclusion, summarise?
Yes, thank you very much. Well, Ron, can I just say thank you very much for your talk from everybody here. I think we've all learnt an awful lot tonight. Hopefully people will go away feeling more reassured. I think your message at the end has been sort of rather upbeat about the vaccine. And I look forward to receiving my first dose of vaccine. Can I